Buongiorno a tutti. No, mi siedo così.
Good morning. I'm going to sit down so I can sit closer to the microphone. Now, this morning I will be talking about a much simpler topic compared to the topics that have been discussed so far. So please do relax. And the beginning of my presentation will be very general. First of all, let me tell you about protocaterin. It is an adhesion molecule. It has an X-linked inheritance, and it leads to interactions among cells and neurons. This is an old slide, an old picture, but it still applies. It clarifies the mechanism of inheritance and also the pathogenetic mechanism. So we have homogeneous neurons, be them wild type female ones or male homozygote types. So homogeneous populations show no phenotype, while a mixed population shows the epileptic phenotype. And this is what they understood a long time ago, metabolic interference. And based on the initial descriptions, this was the cause of the pathogenetic mechanism. Several characterizations were carried out, additional insight was acquired, and the hypothesis was eventually confirmed. The first confirmation came from the detection and description of the first mosaic male in 2009. As you heard today, I'm going to tell you about two mosaic male cases that we recently characterized. This is the first mosaic male that showed a deletion in a region of the chromosome contained the PCDH19 gene, thus confirming the hypothesis that a mixed population of cells and neurons can lead to the manifestation of the epileptic phenotype. Now, the patients, the males I'm going to talk about today, were taken from a cohort of patients that we analyzed. It was a very small panel of genes aimed at characterizing patients with focal or generalized epilepsy in a time frame, or rather with an onset that was compatible with the genes that were represented. This was done using an Illumina technique. We used the TSCA sequencing technique. We analyzed approximately 100 patients and found 3 mutations in female heterozygote patients, and we also found a mosaic mutation into male patients. This slide shows the working flow that we commonly use in order to study protocaterin through the next generation sequencing. Now, the platform that we use for next generation sequencing allows us a fully automated workflow. So you have the DNA input, the variants. So as I said, the workflow is fully automated. No operation involvement is needed, and eventually you get to the variant analysis. However, we are involved in several steps of the workflow. Usually, we are not involved at this stage. We do not perform any realignment. So this is what happens. All the genes are sequenced. They are aligned with the reference genes. There is a sequence being defined and called wild type. It is also stored in the database that we use on a daily basis. After the alignment, we will collect all the variants, all the mutations, everything which in our patient is different from the reference sample. So in an intermediate bioanalysis, we carry out some activities. We perform a quality check of the file, and then we also analyze the variants in an independent way. We use several tools for the variants, and then we also perform a manual inspection in the region that I'm going to show you. We use a software that shows the file and the variants being called or being highlighted will then be validated using the old technique. The mutations I'm going to talk about today, most rapidly with an automated flow, would have been lost at this step, at this stage, i.e. when you control the variants being analyzed, the mutations might get lost. This is because they are present in a very small percentage, in a very small rate. This is the screen I was talking about, the screenshot. This is the reference genome, the wild type sequence, and this is the analysis of the patient's molecule by molecule. In this case, the patient's DNA was read 157 times, and the mutation was called only I don't remember the exact number, maybe 10% of the times. The instrument could read the 10, but its threshold is set by the operators, and according to the type of protocol that we perform, the variant call could be included among false positives. This is why it was excluded. And then we performed a manual inspection. We viewed the region and noticed the presence of a mutation. Frankly speaking, I have to say that the type of mutation, since it was a nonsense mutation, that was very inspiring for me. It was a pathogenetic variant, of course. So we validated it using the Sanger technique. The electropherogram was compatible with the 10% of the allele present. We asked the patient for more tissues. We validated the presence of the mutation in the other tissues. We noticed that the mutation was already included in the database that we use on a regular basis as cosmetic somatic mutation. So somatic mutation in a tumor tissue, in a cancer tissue. This is, I would say, a mirror example. Now, as I told you before, this looked like a perfect hemizygote. So it could be a father, a caring father. The only exception being this small perception of alleles, of DNA molecules, which in fact were still wild type. The instrument called the mutation, considered the mutation as a hemizygote one. We carried out a manual inspection, and frankly speaking, I have to say that in this second case, I was guided by the clinicians, because the clinicians knew already that there might have been a compatibility with a PCDH19 related epilepsy. We performed the blood validation, we requested more tissues from the family, and the electropherogram was found to be compatible with the presence of a Mosaic case. We validated the presence using a quantitative technique, using allele discrimination in real time. The data are slightly different, but I would say the trend is confirmed. I.e., in patient 1, we have a predominant wild-type alleles and a small percentage of mutations, and it's exactly the opposite in patient 2. The clinicians compared the clinical presentation of the two males with a point mutation with a male described in literature, and high phenotype overlapping was noticed in relation to presentation, cluster presentation, fever sensitivity. The IQ in our two males is maintained, So the cognitive profile is normal or slightly borderline. What I would like to highlight is that in all three patients came from a cohort of a patient who were SCN1A negative, and our males had already undergone diagnosis, and they were both SCN1A negative. And this is a piece of information that must be taken into consideration. And now the clinical data. Phenotype of our male patients. It was compared with the clinical features of the females, and a high degree of overlap was found with a specific reference to the type of seizure, the seizure type. I was also told that the EEG pattern shows similarities as well, and I trust them. So the take-home message is the following one, very simply. From the clinical point of view, based on the availability of new technologies once the hypothesis of SC1A is ruled out, we may say that in males with a clinical presentation that is compatible, so we may assume that they can be PCDH positive. Of course, attention needs to be paid to data analysis because we're perfectly aware that, of course, we need to search for a mosaic. This is a paper just to say that maybe we are not that wrong, because in a medical condition that has the same inheritance foundation of our epilepsy, they demonstrated exactly the same thing, i.e. mosaic renders the situation more complex. Mosaic males are more severe. This is a completely different clinical presentation compared to real hemizygotes. And what about the biological message? What changes in the male's characterization? Claudia did not show that before, but as Professor Parent showed, we also came across in trying to solve the issue of inactivation of X chromosome, and in order to correlate our experiment with the data, having males available is going to facilitate us a lot. We will get rid of inactivation of chromosome X, which is a confounding factor. So what about our future plans, and what can we do having male patients available with a protocaterin phenotype? First of all, we want to characterize them even better using the digital PCR. We want to characterize the percentage of mutating alleles, and Claudia is going to use this. We have fibroblast cultures. We do have the fibroblasts of a patient, and for another patient, we don't have any fibroblasts yet. For further characterization, for experimental reasons, or in view of reprogramming of IPS, in our opinion, it's worth to perform a fine characterization of muting alleles using the digital PCR. Having males available can be helpful also to compare using a microRNA profile or a transcriptional profile. It can be useful to compare affected males and affected females in order to try and understand what their common pathway is, regardless of different expressions which are due to chromosome X inactivation. My acknowledgements now. I would like to thank all the people who participated in this project. These are our clinicians who guide us in the molecular diagnosis, and they also carry out patients' characterization and also perform diagnostic hypotheses. I would like to thank my boss, Dr. Bertini, our genetic group, the cellular biology group, and I join Claudia in thanking Francesca, her sisters, Valeria and Paola in particular, who have been supporting us. And I would like to thank our patients, their families, because they help us so much and they're always ready to be studied. Thank you very much. I have a technical question. Now, the somatic mosaic issue is very interesting. We know there's a bias. We found them. So our degree of attention and sensitivity is quite high. This is one of the typical nightmares that we all have. Using Sanger sequencing techniques, this cannot be seen because the Sanger technique is not very sensitive. We are working exactly on the same things, and I have a question on coverage, depth of coverage of the positions. We need to consider a very high degree of coverage. Otherwise, a 10% representation degree will not appear. Now, my question is, what is your coverage mean value for the positions, and what is your coverage cutoff point? These are old pictures, the ones I showed you. Of course, technology keeps advancing, and these pictures date back to 1.5 years ago. With the old panels, we were at approximately 100x coverage. And also to prepare our reports, if we are below 70 or 80 coverage, we won't be able to provide a complete report. Now, of course, the technique is evolving, and we can get a 500x coverage. I don't know what technique you use, but Illumina has improved its flow cells. Let me say that the number of genes was very small. If you increase the number of genes, either you have to decrease the number of samples in the flow cells, but usually we are at approximately 100x coverage. Now, if the clinician already has an idea and informs us in advance, if coverage is not sufficient, then we will make up for that. It's mainly focusing on mild cases, so we do expect mosaics, sure. Now, with panels, you tend to use panels, enlarged or medium panels, and this is the problem of the bias, and this is very difficult when you're working on a patient.
I would like to give you our experience in your technical point. I think that you have not the coverage, but the depth. Depth, the number of reads. And it's in our experience, in our hands, it was very difficult to identify a mosaicism less than 1%, because in this case, it's very difficult to distinguish between the mosaicism and the background. And okay.
That's always true. Although I have to say that if you then have a way to evaluate the quantity, so you have a real-time PCR or a digital PCR, you can then come back to the sample and figure it out. It's not always possible, but this is something that we have to face because it will be seen more and more often. So probably part of the variation or the variability of the phenotype might be due to that, or some of it. So I think it's very important to have this idea up front and plan our experiments accordingly.
I think that a new technology leads to new concepts, I think. But I have a question to Alessandra. Yeah. Did you perform the PCDH19 analysis on a large series of male patients with this phenotype, very close to the phenotype that we see in females with PCDH19 mutations?
It's complicated because even in the design of the panel, we take account of the presentation, the potential eventual presentation of the patient. So the genes are inserted into design if there is coherent, if they are coherent with the phenotype. So all the 100 patients are compatible with the potential phenotype. So I think, I don't know if Marina won't add someone, but I think that all the patients analyzed can be potentially affected by PCDH19. Male patients.
Male patients. But from your work, can we conclude that we have to analyze for PCDH19 gene all male with a Dravet or Dravet-like syndrome, but without mutation in SN1A gene?
Marina può rispondere. Sì.
That we should do it, and it was already done in France, and they found them. So I think that when they result negative for SCN1A, they should be tested for PCDH19.
It's not done in France because it's a very huge amount of work to test all the male with a Dravet or Dravet-like syndrome, but without mutation in the SN1A.
Excuse me, I think we need a workshop on this, but we're running out of time.
Okay.
So